Hello, everyone. Thank you for being here today. My name is Gabrielle Tinsley, registered dietitian, and today in the learning module, we'll be discussing menopause management, specifically focusing on the nutritional and lifestyle strategies that dietitians can use to support women during this life stage. So you may be asking yourself, why is learning about menopause important for me as a dietitian? And a key reason is because of the overall impact. Menopause is not a short transitional phase, but rather a major life stage with long-term health implications. By 2030, it's estimated that 1.2 billion women worldwide will be menopausal. As dietitians, we are uniquely positioned to support symptom management, prevent chronic disease progression, and empower women through individualized, evidence-based care. Our objective today are to firstly describe the physiological and metabolic changes that occur during menopause and their nutritional implications. Secondly, to evaluate dietary patterns and lifestyle factors that may exacerbate menopausal symptoms and propose evidence-based modifications. And thirdly, to integrate current research on nutrients, dietary patterns, and lifestyle strategies to design comprehensive, client-centered interventions for menopause management. As we move through the presentation, I encourage you to think about your current patients. Where are you already addressing these concerns, and where might you be able to strengthen your approach? So next we'll discuss the definitions and the stages of menopause. Typically, menopause occurs between the ages of 45 and 55, though earlier onset can occur naturally or surgically. Let's review some of those definitions. We have premenopause. This refers to the reproductive years before symptoms begin. We have perimenopause. This is the transitional period where symptoms begin and continue until 1 year after the last menstrual period. Menopausal is when that official diagnosis is given 1 year after the final menstrual period. And postmenopausal is the remainder of life after menopause for women. Many women will spend nearly 40% of their lives in postmenopause. For metabolic changes, so estradiol is the most potent and primary form of estrogen, and it has wide-reaching metabolic effects that influence the central nervous system, liver, muscle, pancreas, and adipose tissue. Some of the main effects of estrogen are that it increases insulin sensitivity and glucose uptake in the muscle. It also increases basal energy expenditure and suppresses appetite via the central nervous system. When women enter menopause, estrogen synthesis significantly decreases due to lower functioning ovaries. When this estrogen declines, we see basal metabolic rate decrease approximately 250 to 300 calories per day. Appetite suppression is reduced as well, and this often leads to increased caloric intakes. This explains why many women may report weight gain despite not actually changing anything. So this means that it's not just behavioral, it's actually physiologically driven. Some of the physiological changes associated with menopause include weight gain, like we talked about. On average, women will gain an average of 10 kilograms between the ages of 40 and 60. We also see a shift in fat distribution around the midsection, so central adiposity. We also see an increase in visceral fat accumulation. And lastly, there is a increase in chronic low-grade inflammation in the body. All of these changes increase a woman's risk for cardiovascular disease, type 2 diabetes due to that impaired glucose regulation, osteoporosis linked to a decrease in estrogen, and even tumors, especially hormone sensitive breast cancer. Additionally, 75 to 80% of women experience menopausal symptoms, with up to 30% describing them as severe. Some of the most common side effects or symptoms include hot flashes, night sweats, sleep disturbances, brain fog, mood changes, and joint pain. These symptoms often affect quality of life significantly. So, the role of dietitians. Changing dietary habits during perimenopause is most effectively achieved through nutrition counseling and intervention, especially when led by a dietitian. Dietitians are key to providing individualized nutrition therapy, educating on lifestyle changes, and supporting long-term behavior modification. The typical Western diet that we see as dietitians can actually exacerbate many of the risks associated with menopause. Some of the highlights of a typical Western diet will be a high fat intake, on average, about 38% of our total energy. Also, excess sodium intake paired with a low fruit and vegetable intake and low calcium intake. Therefore, through nutrition counseling, we as dietitians can play a pivotal role in reducing obesity and metabolic syndrome risk, as well as improving bone health, managing cardiovascular risk, and supporting symptom relief and improved lab markers. Rather than focusing on restrictive dieting, more focus should be placed on overall nutrient density, supporting muscle preservation, metabolic support, and cardiovascular protection. Dietary patterns, which we can educate patients on, should emphasize the plate method that can be seen in the graphic on this slide. And we can see that there is an emphasis on high fiber carbohydrates, lean proteins, and healthy fats. Other key nutrients to review with our patients will include vitamin D, calcium, vitamin C, B vitamins, and adequate hydration. And there is ample more information in the assigned readings that go over these nutrients as well. On this slide, we have some practical strategies for implementation. So, as I like to say, counseling pearls that we can provide to our patients. Firstly, we recommend individualizing caloric goals via BIA or bioelectrical impedance analysis and function tests. We do want to keep in mind not to prescribe energy intakes below the BMR, as metabolic adaptations are already occurring, and aggressive restriction often worsens those outcomes. Protein and resistance training are going to be non-negotiable for preserving skeletal muscle mass, which naturally declines with age. We also want to encourage increasing fiber intake, swapping out saturated fats for poly and monounsaturated fats, as well as adding in oily fish. Offer or recommend rather sodium reduction, staying below 5 grams per day, recommending hydration levels at 33 milligrams per kilograms per day, And then speaking with our clients based upon a structured follow-up schedule. This is going to be critical as plateaus should be expected around week 12. We'll want to cancel patients around these expected plateaus accordingly. Some other education items to consider will be based around meal timing, label reading, alcohol moderation, and sleep hygiene. Regarding suggested nutrient ranges, research recommends at least 1 to 1.2 grams of protein per kilogram per day, which is of greater than or equal to 20% of our daily energy needs. At least 120 of carbohydrates per day, limiting saturated fats to less than to 10% per day, while also emphasizing those polyunsaturated fats specifically, including EPA and DHA. For fiber, we recommend at least 25 to 30 grams per day and up to 35 to 45 grams per day for cardiovascular disease prevention. And then for added sugars, ideally 5% or below. However, it can be a little bit more liberalized with less than 10% of our energy needs per day. There is emerging evidence that shows that menopause is associated with dysbiosis and reduced extrabolome activity. Extrabolome influences circulating estrogen metabolites, and reduced activity of these enzyme producing bacteria in the gut may worsen symptoms. We know that dietary fiber supports our short chain fatty acid production, improves glucose regulation, reduces inflammation, and supports a better intestinal barrier integrity. So, probiotic supplementation shows some favorable cardiometabolic effects through though dietary diversity remains foundational. With our patients, we of course want to encourage those high fiber diets while also encouraging diverse plant intake and fermented foods. Soy foods, so not supplements, those actually may reduce hot flashes. There is some suggested intakes from the Provide studies and readings. Recommended is about 20 milligrams of isoflavones per day for symptoms relief, which is about 400 milligrams, or pardon me, 400 milliliters of soy beverage or 80 grams of tofu or tempeh. Population data does not show increased breast cancer risk with typical food-based soy intake. However, supplemental isoflavones require caution. We will want to coordinate with oncology for patients on anti-estrogen therapy, such as tamoxifen. For safer guidance, we can educate our patients to aim for 10 to 15 grams of soy protein per day from whole foods within the context of a balanced diet. According to the Menopause Society, which has a lot of great information, there are no dietary supplements or herbal remedies that are recommended as effective non-hormonal therapies for menopause symptom relief. Supplements are not regulated for safety or efficacy by the FDA prior to sale. So, as clinicians, if patients do want to take some sort of supplement, we can recommend them to look for a third-party certification with the USP or NSF label, avoiding multi-ingredient blends, monitoring for side effects and interactions, and prioritizing lifestyle interventions first. Patients often look for quick fixes, and our role as dietitians is to recenter that care on sustainable foundations. Creatine. So, creatine is one of the most researched and reliable supplements available. Women typically have lower baseline creatine stores, and the estrogen decline associated with menopause may further impact muscle preservation. When combined with resistance training, creatine has the potential benefit to support muscle strength and preservation. It may improve energy metabolism and reduce fatigue. And there is some potential for it to support cognition and mood. Creatine is generally well tolerated. However, there is some possibility for water retention and mild gastrointestinal discomfort. The typical dose is 3 to 5 grams per day, and we do want to proceed with caution for those individuals with kidney disease and consult a healthcare provider prior. Creatine may be one of the few supplements with meaningful clinical utility in the menopausal population. And lastly, we have some other important considerations for supporting that healthy lifestyle, specifically with sleep hygiene and exercise. Both are going to be foundational. Poor sleep of less than 7 hours per night increases cardiovascular risk, increases appetite and energy intake, leads to increased weight gain and glucose dysregulation. We want to encourage a consistent meal timing pattern, have patients consume dinner at least 2 hours before bed, recommend evenly distributing our fluids throughout the course of the day, and then also offer different nutrients that support melatonin synthesis and tryptophan containing foods. For exercise, we recommend a minimum of 150 minutes of moderate intensity physical activity per week, a minimum of 2 of those days of muscle strengthening activities. Tai Chi may be specifically helpful in improving sleep, stress, and hot flashes. So, meeting these exercise recommendations will help to maintain or gain muscle mass, improve pelvic floor health, reduce the risk of osteoporosis, while improving quality of sleep, balance and joint function, cognition, and our mood or response to stress. So I hope all of these nutritional and lifestyle considerations were helpful today as you meet with your menopausal population. I hope you enjoyed the case studies and the assignments and readings, and don't hesitate to reach out if you have any questions at all. Thank you so much.